Welcome to Pharma Docs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hello, John. How are you?
Jay, good evening. How are you tonight?
Good. Hopefully the winds we have here again today will not knock out my power.
What kind of winds are you having?
They're variable from anywhere from like 15 to 25 knots. So they're
gosh.
Yeah, it's pretty windy.
Well, we just had another beautiful day here, so no wind at all, and but we're getting ready for the spring getting here, and we get a lot of pollen, Jay. Oh gosh, we get a lot of pollen.
Yeah,
tremendous amount.
Yeah, not quite as much in LA, but still, it's the time when most people who have hay fever, that's when they suffer.
Well, I got great news for you, Jason. Since the last time we spoke on this great show, we've already had 3 new drugs approved. So here we go again. They're starting to release more and more drugs. So, it's just safe to say, guarantee yourself about 50 new medications coming out every year. And we have to know what they are. Just like the first drug that Vonjo. Okay. Yeah. All right. So a patient comes in, hey, I'm on Vonjo. All right, what's that drug for, Jay? It's myelofibrosis. Okay. It's for a patient that's got thrombocytopenia, which means low platelets.
Right. Yeah. It's also used in patients that have acute myelogenous leukemia.
That's correct. All right.
So it's got
leukemia. They're
more than one.
Immunosuppressed patient now. Okay.
Yeah. Yeah, it's basically, so we talked about before, how with the monoclonal antibodies, how you can UMAB or MAB is the suffix. This drug is pacritinib, and whenever you see INIB, inib as the suffix to it, or the last part of the name, that means that it is a drug that inhibits something. And in this case, it inhibits JAK2. We've talked about Janus kinase before. Yes. And FLT3, which is an FMS-like tyrosine kinase. So it inhibits both of those enzymes. And it's used for treating, again, patients that have myelofibrosis, patients that have thrombocytopenia. I can't talk tonight.
That's right.
And so these 2 signalers, JAK2 and FLT3, they're important to signaling other cytokines and growth factors that are involved in hematopoiesis. And what happens in myelofibrosis is there is a mutation of both of these enzymes, the JAK2 and the FLT3, that results in kind of discoordinated, dysregulated signaling involved with blood cell development.
Well, as we all know, platelets are called thrombocytes, and that's the type of cell that, they form blood clots to help us stop bleeding at the site of a cut or a wound or an extraction site, Jay.
Yeah, exactly.
So, we're always concerned about a low platelet count, and because you're going to have bleeding.
Yep, sure are. So myelofibrosis is one of the myeloproliferative diseases. That's how it's categorized. It also is categorized as a type of leukemia. And so it's a bone marrow disease where there's fibrosis of the bone marrow. And when the active part of the bone marrow is replaced by fibrous tissue, of course, what's going to happen? There's going to be decreased production of white blood cells, red blood cells, platelets, and that's going to lead to the problems and the symptoms, which are basically what you would expect in an anemia: fatigue, easy bruising, fever, bone pain, shortness of breath. Usually the tiredness and the fatigue and shortness of breath is due to the anemia. Patients may also have pain under the ribs on the left side, and that is actually due to enlargement of the spleen, because what's happening is the platelets are being basically removed from circulation in the spleen, and so the spleen enlarges, and so that'll cause pain.
So the disease states, Jay, that we all need to be thinking about. I mean, number one, that could cause a thrombocytopenia in our patients would be number one, the alcoholism.
Yeah.
Okay.
Yeah.
All right. So somebody that abuses alcohol, that's a patient red flag right there.
Right. Right.
Okay.
Yeah.
Or autoimmune disease, or bone marrow diseases, aplastic anemia.
Yeah. I mean, we can basically break down these different anemias into increased production, increased destruction of the cells, increased sequestration of these cells, or decreased production. So alcohol reduces, I think it causes more destruction.
Yes.
And autoimmune, of course, you're having less production of the various blood cells. And same thing with cancer treatments. They can affect the bone marrow and result in decreased production of blood cells.
So before this, Jay, the only other treatments would be blood transfusion, but that only temporarily increases our platelet levels within our circulatory system.
Yeah. They'd also do splenectomies.
That's right. In about 3 days, you're going to be right back to where you were.
Yeah.
Then, like you said, a splenectomy or
steroids. Yeah, steroids will reduce the destruction of the blood cells as well as stimulate production.
Right.
So it works on 2 of the 3 factors.
Right. So just like over the last 3 shows, Jay, we've had brand new drugs come out that, they're basically first in their class to do something. Okay. And so, again, this continues to be exciting times because just those 3 that we just talked about was basically the only thing to be done for thrombocytopenia.
Yeah.
So now we have Vonjo. Okay.
Yeah. All right. The next one is Reluco.
Reluco. So I have to think Reluco. Okay.
Reluco, Releuko, and that's
right.
Filgrastim -AYOW, and it's injectable.
Yeah.
And this is for neutropenia, decrease in white blood cells associated with chemotherapy, and neutropenia, obviously, from other causes. And it's a granulocyte colony stimulating factor, GCSF, and it's biosimilar to Neupogen. And so Neupogen is filgrastim also, but Reluco, because it's a biosimilar, it's got that suffix at the end, AYOW. What does that suffix actually mean? Nothing. It's actually they select 4 random letters as a suffix for similar drugs. So it basically works in the same way, but there's a little tiny bit of a difference or as far as the structure of it from the drug that it's similar to. So these drugs are used to stimulate blood cell production, and it's used in different blood cancers, leukemias, and patients who've had radiation for cancer that has affected the bone marrow, and also in, let's see, who else is it used in? Mostly those 2 groups.
But Jay, talking about the white blood cell count, as we all know, they're used to help us fight infection. Okay,
right.
And then a lot of times, when we get more specific on the neutrophils in the blood, we'll get into what's called the ANC, the absolute neutrophil count.
Yeah.
And that's critical right there, because the probably the low end of that is around the 1,500 neutrophils per milliliter in an adult. Okay.
Yeah. Some people do the cutoff at 1,800, but for most labs, 1,500 neutrophils per microliter is their bottom cutoff.
Yes.
And so we can categorize neutropenia into mild, which is between 1,500 down to 1,000. Moderate, which is from 1,000 down to 500, and under 500 would be considered a severe neutropenia. And it can be something that's acute, develops, very short term or temporarily. It can be chronic. It can be congenital, or it can be acquired due to a number of conditions, and it'll gradually gets worse over time.
And of course, you think about a low ANC, absolute neutrophil count. What comes to mind? Cancer. Okay.
Yeah.
And
first thing to think of.
Because as we discussed, probably about 50% of cancer patients are going to have a low white blood cell count.
Yeah.
And they're going to need agents like this as well to
Right.
help increase that so they can fight infection during this,
Exactly.
this hideous disease.
Yeah. Now, interestingly, there's some ethnic groups where the ANC can be as low as 1,200 and still be considered normal. And those are African populations, Yemenite Jews, and Arab populations. And so it's actually called ethnic neutropenia.
Okay.
Even though it's not really a neutropenia, it's normal for those groups.
So some of the causes, Jay, as far as what leads to neutropenia, where the neutrophils get used up or destroyed faster than they are produced. This would include like hepatitis, tuberculosis, sepsis, Lyme disease.
Yeah.
Of course, we've already talked a little bit about cancer.
Yeah.
And then, of course, the medications to treat cancer is chemotherapy.
Yeah. In fact, I think about 50% of the cases of neutropenia are actually in cancer patients.
A side effect of the chemotherapy. That is correct.
Yeah, exactly.
And then, of course, when you have deficiencies in your vitamins, such as vitamin B12 or folate, that could also lead to it. And then some autoimmune diseases as well, like Crohn's disease, lupus, and RA or rheumatoid arthritis.
Yeah. Yeah. So the take home message, of course, is a patient who is on these medications is going to be more susceptible to infection. So just like the patients who are on Vonjo, they're going to have some suppression of their white blood cells. And so you have to cover them with antibiotics because of their higher risk of infection.
And Jay, every one of us out there are going to see cancer patients in our offices while they're undergoing treatment. They may get an abscess tooth. And it's going to be vitally important that you know it when you call and speak to either the hematologist or the radiation oncologist or whoever is managing their cancer, to find out, hey, tell me about their ANC, their white blood cell count, and as you said, you definitely want to cover
and their platelets too.
And their platelets. That's correct.
Yeah.
So, again, we're all on this team together because if a patient is disrupted during their chemotherapy due to a tooth, that's not a good thing.
No,
because they're on a strict regimen of therapy right there.
Yeah, and if they've got an infection and they can't fight the infection, of course, it can really have some adverse consequences.
That's correct.
Yeah.
All right. So 2 good drugs there. All right. What's our third drug, Jay?
Our third one is Norliqva, Norliqva, and this is not a new drug. It's a different form of an old drug, amlopidine. And amlopidine as Norvasc. And a lot of patients, it's a very common drug for high blood pressure. It's a vasodilator. So it causes dilation of the smooth muscle in the arterioles. And so it reduces what's called the afterload or the peripheral resistance to blood flows, and that's how it reduces blood pressure. And what's different about Norliqva is it's an oral solution. So for patients who have trouble swallowing pills, and it's peppermint flavored. So I guess it's good around the holidays.
So we finally have an oral solution for a calcium channel blocker.
Yeah.
So, and I just think, again, like you said, because there are a lot of people out there. I mean, I just had somebody last week, like, I can't swallow pills and I have to give everything to them in liquid. You're going to see it all the time in your practice.
All right. See them all the time.
Okay, let's get back to our discussion. on the top 10 drug to drug life threatening reactions. And, we already covered about Coumadin and NSAIDs, and then Coumadin and sulfa drugs.
Right.
And so now let's talk about another class, Coumadin and macrolides. And we all write macrolides, Jay.
All the time. It's like erythromycin, azithromycin, clarithromycin. So your Biaxins, your Zithromax and Biaxin are all macrolides. And the way that they interact with warfarin is in two ways. One is the macrolides affect the cytochrome P450 system, the enzymatic breakdown of the warfarin in the liver. And so by reducing the amount of it inhibits the clearance of warfarin from the body in the liver. It also affects the oral flora, and so that reduces the amount of vitamin K dependent clotting factors that are produced by the bacteria in the gut. And so both of those lead to an increase in the PT or INR because you have greater clearance of the warfarin from the system. So it's as if the patient's not taking enough.
And Joe, the interaction between Coumadin and a macrolide antibiotic is highly probable.
Yeah.
And often delayed.
It's expected, yeah. But
and so
it can take time.
Concomitant use of it, if you can, it should be avoided. Now, let's say you have that patient comes in. Let's just say you have that cancer patient that comes in with an abscess, and they're also on Coumadin, and they're allergic to everything but maybe one or two macrolides that you announce to them, like, hey, have you ever taken this drug? No, I haven't. Okay. Yeah. So you do not want to prescribe that by yourself without some type of medical consultation to the physician that has them on the Coumadin, because they're going, if a macrolide has to be used, Jay, if that's the last choice, then the INR is going to need to be monitored every other day. And there's going to need to be dosage adjustment to the Coumadin as well, too.
Yeah.
Right?
It takes.
That's what I just said. This stuff is highly probable. They know this is a bad interaction.
They expect it to happen.
Coumadin and sulfa drugs.
Yeah. So, it takes about 3 days for a change in the Coumadin dose to be reflected in the INR. So there's going to be a little bit of a lag, but definitely, if that's the only drug that you have to use, that you can use safely in the patient, then you've got to, in consultation with their cardiologist or whoever has them on the Coumadin, you've got to really tightly coordinate this patient's Coumadin dose. Otherwise, you're going to end up with bleeding that, not only bleeding from, let's say, an extraction socket or periodontal surgery, but you're going to have bleeding in other areas. You're going to have bleeding into the stomach, which causes the patient to vomit blood. It's called hematemesis. You may get bleeding in the lungs, which is hemoptysis. They may have nosebleeds. They may have bleeding from their gingiva. They may have blood in their urine, which gives them hematuria. And in the lower GI tract, you get blood in the small intestine and colon. Then it turns the stools dark and tarry, and that's known as melena or melanotic stools.
So every cardiologist would love to hear from you before you do this, Jay. Okay.
Yeah.
That they want to follow that patient closely with you as well to prevent all of that, because, hey, they're with you every step of the way with this. And if we can avoid every side effect you just said, job well done.
Right. So, John, let's say we don't have a lot of choices and the patient says they can take Cipro, do we have to worry about anything? And of
absolutely.
Course, exactly. The quinolones have the same reaction or the same interaction
That's
with
right.
warfarin to increase the warfarin level. Now, they're not sure exactly how that works, the exact mechanism, but they do know that because of alteration of the GI flora, that it will reduce vitamin K, the bacteria that produce vitamin K, and so you don't have vitamin K around for those clotting factors that require vitamin K.
So, and Jay, even if they weren't so hard to get into an infectious disease doctor, you could also have them tag along with you as well, as
Mhm.
far as antibiotics were
Yeah,
concerned,
yeah,
because they are the experts in that,
right.
and to work alongside with you and the cardiologist that prescribe that
Yeah,
drug.
yeah,
Again, it's all about consultation and documentation. Okay. I mean, especially when you get in these delicate situations like this. All right. It's
yeah,
not like, oh, you're on, Coumadin, no big deal. I'll just write you for a Z pack.
yeah. Exactly,
Um,
exactly.
and that
And
Z pack,
the patients won't be aware most of the time.
no,
Yeah,
until they get one of these side effects that you just
right.
described very
Yeah,
good to us on
yeah,
the
yeah. When they
show
start
right now.
bruising and bleeding, they'll know something's up.
So, so there we go. So we talked about sulfa drugs last week or 2 weeks ago. Now we talked about the macrolides and the quinolones, because again, if let's say you don't have any choice at all and you get down to the quinolones, well, Cipro is a good drug.
Mhm.
All right.
Yeah,
And I've
it's
used it
good against the
before.
oral flora.
That's right.
But again, you're going to have to monitor, if that's the only thing you can use, monitor the INR every day, consult with the hematologist or cardiologist to decrease the Coumadin dose, and they're going to do it incrementally. They're not going to just stop it. Um, Reduce it incrementally so that the patient doesn't have all these bleeding issues.
Well, the other bleeding issue, like, will be primarily our extraction site as
Yeah.
well, too, because even though we covered all those other ones, that's an area that's going to bleed.
Hmm.
And both the quinolones and the macrolides are in every other check that INR.
Yeah. Exactly.
Don't
Exactly.
do don't do this alone.
Yeah. And sulfa drugs we talked about last
Right.
time. Yeah.
You're not going to probably speak to the cardiologist. You'll get their nurse, and then they're great. They look forward to hearing from us, and then document that or they'll fax over or email something,
Yeah.
the treatment plan with you as well too.
Exactly. Well, let's
Okay.
shift gears and talk about, since we've mentioned it a bunch of times already in the last 10 minutes, INR. And INR, again, is the International Normalized Ratio. And what it is a way to standardize the PT results across different labs. So every lab will have a little bit of a difference in how they measure PT, prothrombin time. But what the INR does is it makes it uniform from lab to lab, consistent.
And we talked about all this, Jay, on our last show.
Yeah.
First, got into the INR, and then we were coming up on what is the target range of INR and the duration of the treatment.
Mhm. Yeah.
And most people agree that target range is 2.0 to 3.0.
Yeah.
Okay, so and they're going for about a 2.5 right there.
Yeah.
All right,
Yeah. Yeah.
and that's typically what we see for, like, patients with AFib.
Right.
And we're going to see a lot of those patients. Okay.
Yeah. Yeah.
Eh,
And different valvular heart disease.
the valves, that's
Yeah.
right. Correct
Yeah.
as well, too.
Yeah. And for patients that have mechanical valves, they tend to have a little higher INR for those because they've got a much higher risk of developing clots.
Yeah. Yeah. You might see a 3 to 3.5 on that valve, right? On that valve patient, I
Yeah.
should say, as
Yeah.
well, too.
Yeah. And it's also in patients who've had thrombotic events like a deep vein thrombosis or a pulmonary um, uh, PE, a pulmonary embolism.
So besides DVT or a PE,
Mhm.
or AFib or valvular heart disease, there can also be cardiomyopathy.
Right.
Okay.
All
And so
those things can increase the risk of clotting.
yeah, so
Yeah.
if you've got a patient in there, Jay, that's suffering from cardiomyopathy, you have a very sick patient in your office.
Yeah.
Okay.
Yeah. So some patients are on warfarin or Coumadin for their whole lives, and some are on just for a short duration. So generally, if the patient develops a provoked DVT, let's say they were on an airplane for 8 hours and didn't have to get up to go to the bathroom the whole time, then and they develop a clot in their leg, those patients only need to be on the blood thinner for about 13 weeks. But if it's an unprovoked, it's again 13 weeks, but depending on the patient's overall clinical context. So, like if they've had a DVT before or a PE before, those patients, it's appropriate for them to be on Coumadin for their lifetime. And of course, for patients that have AFib, cardiomyopathy, and valvular disease or valve replacements, that's also a lifetime drug.
Correct. And also remember, on valve replacement patients, we will be pre-medicating with antibiotics.
Yeah. Yeah. Yeah.
And so sometimes, again, we talked about it 2 weeks ago. You may be told by that cardiologist or a thoracic surgeon, I don't want you to stop my Coumadin.
Right.
All right.
And generally we don't, in my practice, I have not stopped Coumadin on a patient in 25 years. There were a number of articles way back that suggested or actually showed that the risk of taking them off of an anticoagulant for an oral surgery procedure is much less than the risk, or taking the risk of when you take them off is much higher than the risk of having increased bleeding from an extraction site or some kind of intraoral surgical procedure. And so I haven't taken, as a general rule, have not taken the patients off of Coumadin. Sometimes their cardiologist just tells them, like, a couple days before to stop taking it, 3 days before. But I don't tell my patients to stop their Coumadin. Now, I had a patient I saw yesterday who's got all kinds of medical problems. He's going through, I think he's got leukemia. He's got some heart issues. He's overweight. He's got, I forget all the things he had, but his INR it was 3.7 last week when they checked. So I said, well, I'm not going to do your surgery until you're down around 2.5, because that's 3.7 is just a little too high. So he said, okay, I'll just go home and eat a lot of broccoli. So what that does is it increases because broccoli as well as spinach and cabbage have a lot of vitamin K.
Vitamin K.
So it increases the production of the clotting factors and counteracts what the Coumadin's doing.
So, Jay, when you have that patient come in your office on any of these problems right here, they may not only be on Coumadin, but they might be on 81 milligram aspirin.
Yeah.
And you might be thinking, wait a second, why? Okay, well, as we've already told you, the Coumadin is for those different disease states of DVT, valvular heart disease, cardiomyopathy, AFib, but they're on aspirin for CAD, coronary artery disease. Okay. Right. So there's two different purposes. You're like, great, they're on two blood thinners. Yes, they are. They're serving two different purposes right there. So that's why you're like, well, you might scratch your head and say, wait, why are they on the aspirin as well too? For CAD.
Yeah. Now, how often do you have patients who are on aspirin who, let's say they're in their 50s or 60s and they have no cardiac issues? How often do you see those?
I see a lot of them.
Yeah.
And I'll say, who started you on it? So, my family doctor said when I was about 40, I probably just needed to start taking this 81 milligram, or they self-medicated themselves.
Exactly.
Okay?
And I read a couple articles a couple months ago saying that that's actually probably not a good idea, that the risks of taking daily aspirin when you don't have cardiac disease are higher than the risk of having a cardiac disorder because of not taking it as you get older. So
Yeah.
they're
They
advising,
changed that, Jay. Remember, before it used to be, yes, that was a good idea. And then
yeah,
they went
and
back.
now
I
it's
mean,
like, no, it's not a good idea.
6 months later, they'll be changing it again,
Yeah.
So
So if you're taking it,
what water's not good for you.
if you're taking it for prophylaxis and you have no cardiac uh, disease or risks, you probably should not be taking aspirin on a daily basis.
No. All
Yeah.
right. So does the INR cover just Coumadin, Jay, or what about the other anti-oral coagulants?
Mostly for Coumadin, because
That's correct.
but there are some drugs that have some effect, like Eliquis or apixaban may affect the PT, and it
That's right.
also may affect the APTT, which is measures the intrinsic pathway, whereas PT measures the function of the extrinsic pathway. So that drug can affect um, uh, the pro time, and so can Xarelto. So that's rivaroxaban. It's easier to say Xarelto. That can also affect the patient's prothrombin time. But just because the patient has normal PT doesn't mean that they're not on those drugs. So you can actually have significant levels of both of those drugs in your system, and it may not affect the PT. So they may have a normal PT, whereas Pradaxa will affect the thrombin time as opposed to the PT or INR, because that acts more. That'll be detected um, in. Oops, what happened to John? That'll be detected in the common pathway, the basically conversion of fibrinogen to fibrin, and the formation of the clot is affected by Pradaxa. So that's basically what we were going to cover tonight. I don't know what happened to John, but we're looking forward to seeing you in our next episode, which will be, I think, number 11. On March 24th. So in 2 weeks, we will be back at the same time, same channel, 5 p.m. on the West Coast, 8 o'clock Eastern time. And until then, we wish you good night, and we will see you in 2 weeks.